Hello, I'm Dan Gilden. I'm the program director for the Emmanuel and Good Samaritan Legacy Internal Medicine program. And I'm welcoming you to this YouTube video that we're using for our interview days. We're doing this for multiple reasons. One is for people that are applying categorical. This gives you a better idea of what our program is all about prior to your visit, and then can use your interview day more for questions and answers to more specific questions. And then on the preliminary side, we do a lot of Skype interviews, and this acts as the introduction to our program for those preliminary applicants. So what is Legacy? Legacy is a number of different hospitals. The program is run out of Emmanuel Hospital in Northeast Portland and Good Samaritan in Northwest Portland. There's also Randall Children's Hospital, which is on the Emmanuel campus. There are 4 additional hospitals that are in the periphery of Portland, and then we take part in a consortium with Kaiser, OHSU, and Adventist Health for the Unity Center for Behavioral Health. Emmanuel Hospital acts as the county hospital for medicine for Portland. We don't have a county hospital system like LA County in Los Angeles or Cook County in Chicago. Patients go where they go, and they come to Emmanuel because this is the most diverse part of the city. We are taking care of the sickest patients. We're a level 1 trauma center along with the university, but unlike most areas where the university is the regional burn center, Legacy Emmanuel is the burn center for Oregon and Southwest Washington. We're also one of the largest adult ECMO centers on the West Coast. During the 2009 H1N1 epidemic, we were running up to 6 patients at a time on adult ECMO. Good Samaritan Hospital, as I said, is in Northwest Portland. This is the part of Portland with the most restaurants and evening activities. The hospital itself is more of typical of a community hospital. There's a very high Medicare population. We run a geriatric inpatient service that our interns take part in. And we also have a consortium with OHSU to do oncology care at Good Samaritan. The residency program, our program directors are myself. I've been at Emmanuel since 1990 and have been program director since 2011. Paula Folger is a geriatrician and is in charge of our curriculum. Dr. Lenny Mankin is an outpatient doctor and is in charge of our educational curriculum. Mike Ann Minter is a hospitalist in charge of evaluation. Liz Estabrook is a hospitalist in charge of our medical student rotations. And Dr. Deering is our preliminary program director. So for those of you who are applying to the preliminary program, Dr. Darcy Deering and myself will help with your curriculum when you come here. We have 2 current chief residents, Dr. Rebecca Corbett, who's going into Pulm Critical Care, Dr. Rob Morgan, who is going to become a hospitalist. Next year's chief residents are Dr. Jeremy Kim from University of Washington and Dr. Stefan Christensen, who is from Western Osteopathic. Unlike most other internal medicine programs over the last decade who have trouble recruiting for the chief medicine resident spot, everybody who's been asked to be part of the program and part of the residency program as being the chief resident has opted to take part in that role. And it's been part of the rationale of people want to work at Legacy, they want to be part of the program, and they want to be chief residents. Our residents, as you can see in this video, in this picture, they do both inpatient and outpatient care, and then there's also a large wellness curriculum, which we'll go into in more detail. I'm now going to go over the schedule for interns first. So we have been on a 3+1 model, which we are altering slightly to more of a 2+2 model. This was going to give us better continuity for the patients as well as the house staff. It also is going to give better chunks of time for electives, but will not change the overall amount of inpatient medicine. There'll be about 5 blocks of medicine that's split between Emmanuel and Good Sam on the wards. There'll be 1 month of ICU. There'll be 1 to 2 months of night medicine. There'll be continuity clinics that are going to be done mainly in +1 or +2 weeks throughout the year. There'll be 2 weeks in the Emmanuel ED. There'll be 1 month of elective. The categoricals will get pulmonary, geriatrics, and transitions of care during their internship. Preliminary medicine will get additional elective months. In year 2, it's very similar to year 1, but instead of having pulm, geries, etc., you'll have cardiology, electives, and more ICU. In year 3, there'll be 2 additional weeks in the Emmanuel ED, and then there'll be additional subspecialties in hem-onc, GI, nephrology, and neurology. Our ward setup is a senior resident and an intern. We have 1 to 2 medical students at a time per team. At any given moment, we have 5 students, 5 third-year students on both sides, 3 from OHSU and 2 from Western Osteopathic. All of our care is done multidisciplinary, including daily rounds with PT, OT, speech, social work, and nursing. We don't have a call schedule per se, because our longest shift is 14 hours. On the wards, what that means is you go short shift, long shift, and most of your admitting is done on the long shift day. Unlike some of the other programs you're going to interview at, we have maintained the ACGME cap of 14 patients. Our goal on a daily basis is for teams to be working at their capacity, which we view as a sweet spot of around 9 to 11 patients. If we had a lower cap, like 10 patients, that would mean that sometimes teams might run 4 or 5 patients, which is not going to be enough of a clinical experience. Now, because we have a cap of 14, we do sometimes hit 14, but since you are in sync with your attending, who's a hospitalist, they'll know that you're at 14 patients, and we work together in team care to do the best care we can for our patients. In the critical care rotations, we again have 1 resident, 1 intern teams. We again are taking care of the sickest patients in the city. And what we do is run long shift, short shift for the 2-week rotation. So you're alternating long, short, long, short. Because we don't have very many fellows, we do have an OHSU critical care fellow who is at Emmanuel during certain blocks. But even when the fellow is there, the residents are first in line for all procedures. And it's not at all unusual for our house staff to have 50 or more central lines during their 3 years. The house staff is responsible for all codes in the hospital. So how do we run a program that only has 14-hour shifts? What we do is we work our night medicine team very hard. So the senior resident on the team is covering the ICU. The intern is covering the ward teams. And they're also taking admissions from the ER. And at any given time, we have 3 teams that are on night medicine. One team is doing 4 nights at Emmanuel, 2 nights off, 4 nights at Good Sam, 2 nights off, and rotating through the 2-week period that way. In reality, what this turns out to be is 4 very busy nights at Emmanuel, 2 nights off at home, and then 4 not as busy nights at Good Sam. So there is backup available. We have intensivists in-house until midnight, and we have hospitalists in-house 24/7. I do not see a way in the near term that we're going to change this model. We want people to work hard when they're here. We never want people to work beyond what they feel comfortable, so we want to have backup in place. But we also don't want lots of teams in the hospital at night where you're spending tons of hours but not necessarily doing lots of work, and then also making education in all other arenas less effective. The continuity clinics, we run a clinic at Emmanuel and a clinic at Good Sam. It's done in a medical home model with multidisciplinary support, including social workers, pharmacists, and psychologists, and all of the precepting is done by dedicated outpatient attendings. Our education is centered around Wednesdays. So on Wednesdays, we have academic half day. So in the morning, the senior residents leave the wards at 9 a.m. and go to academic half day. They generally have 2 hours of didactics and then an hour of fun after that, which might be cases or journal club. Then at noon, we have medical grand rounds. And then in the afternoon, the interns have academic half day, which starts with a couple of cases, and then there's a couple of hours of didactics. There's additional morning reports that occur after night medicine on 4 additional days per week. There are many cases that we present at grand rounds, and then we are also doing cases at academic half day. I run chief of service rounds on each side of the river once a week, where each of the teams presents a case in a morning report format. We have multiple visiting professors a year. The most notable is Gurpreet Dhaliwal, who's the preeminent case discussant in the world. He has been coming to Legacy yearly for about the last 11 years, and he rarely does other visiting professorships, but loves the way he's able to organize his days and do case reviews with the house staff and at grand rounds. And so he plans on continuing being a yearly discussant at our grand rounds. We also have an annual critical care and hem-onc visiting professors. And then we also have other specialty visiting professors, such as a person who's coming in October to talk about Suboxone in both the inpatient and outpatient arena. And we have simulation and ultrasound. So the sim lab is run by our chief residents bi-weekly with code and emergency training. There's ultrasound available for central line training. And we have an evolving ultrasound curriculum on the inpatient side with bedside ICU point of care training, as well as an ultrasound elective. We have an ever-evolving curriculum that is a consortium between the house staff and faculty in terms of making changes to our curriculum. Our first big change occurred because of board pass rate. Traditionally, programs in internal medicine have had about a 10 to 12% fail rate. The most recent boards had about an 8% national fail rate. We started working hard on our board pass rate over about the last 6 or 7 years, and we now require all of our house staff to do an in-training exam yearly. We have purchased an ACP board prep curriculum, which gives us about 65 lectures from the ACP that they view as pivotal to internal medicine training. All of the house staff get MCSAP during their second year. And then what we added about 4 years ago was a national board review course that gets piped in to Legacy from Phoenix. And since we have implemented all of these aspects to the curriculum, we've had a 100% pass rate, which is obviously much beyond what would be expected for an internal medicine program. We additionally, a few years ago, started something we call GRIT, which is Graduated Responsibility and Training. If you think about internal medicine training, there's two very odd transitions. One, when you move from internship to being an R2. And then the other funny time is one day you're an R3, and then the next day you're an attending. So we have tried to smooth out these transitions, and this occurs during the last ward block of the year for interns and for R3s. This started because a few years ago we had an extra senior resident spot that was unfilled in the 13th block of the year. So instead of having another senior float in and do that, we instead said, well, these are two interns who are next month going to be senior residents. Why don't we see how they can run the team together? So it's as if they're being practicing as an R2. And both of them thought it was an amazing experience. So that was our first time that we tried this. It was a total accident. And then from there, we've expanded the GRIT such that we now have two major things we do. In the last blocks of the year, we run half the teams with two interns running the team, both for patient care as well as for med student education. And then the R3s are practicing to be independent hospitalists, and they work one-on-one with one of our inpatient attendings, and the R3 runs the service with minimal supervision from the hospitalist. We are in the process of creating a situation that all third years will do some hospital GRIT so that they are comfortable at being independent in the hospital, and then they will also do some clinic GRIT where they are going to be acting independently in the clinic. So there have been some other things that have recently been added to the curriculum, and this has been at the request of the house staff. The residents had wanted more outpatient education, so we've purchased a Yale online curriculum that is presented at clinic conferences on a regular basis, run by our clinic attendings. The other thing that we've added in the last year is our education that we think is important for house staff with the opiate epidemic. And our expectation now is that all house staff will have gone through the 8-hour Suboxone course. They don't have to get their waiver for Suboxone, but we want everyone to have gotten that education. As I said, our goal is for you to work hard when you're here and then get out of the hospital. And we do this by really emphasizing our inpatient, our time you're here. We want you to be busy and not just logging more hours. So our longest shift is 14 hours. You do get 4 weeks of vacation. So everyone gets 3 weeks when they want, and then everyone gets 1 week over the holidays. We split our teams up into half. We split the residency up into half. Half works Christmas week, half works New Year's week. We have a evolving wellness curriculum. A few years ago, we had a psychologist as part of our program, but when he retired, instead of hiring another psychologist for the program, we partnered with OHSU to use their wellness curriculum to give counseling services to our house staff. This is anonymous, free. We have no idea who's been up there, but the people that have had needs are really getting incredibly expert advice and assistance from people that are used to training in counseling, clinical, medical people. We also have a peer support program with house staff that are trained in giving support. We run regular well-being seminars, both at academic half day and in retreats. The other thing that we've added in the last year or so is 4 scheduled half days off during the year to be used to support wellness. It might be going to appointments. It might be going for your family to be going to appointments. It's scheduled time off to work on your own wellness. As I said, we run 4 retreats a year. Some of the retreats are purely fun, like going to the Columbia River Gorge on a hike. Most of them have an educational background and then have a fun activity afterwards, such as curling or bowling or rafting. What do our residents do next? So we have 16 residents a year, and our 2018 graduating class is pretty typical. We have 10 people going into hospitalist, of which 4 are staying with Legacy. We have 2 people going into outpatient internal medicine. We have 2 people going into fellowship, one who is doing critical care up at OHSU, and one who's doing infectious disease at the University of Iowa. And then we have our 2 chief residents. Over the past number of years, this has been the breakdown of our fellowships. And I'm going to mainly speak of the top 3. So most of our residents are either going into home crit care, Jerry's, or palliative care. And I actually view them as all kind of similar because we are taking care of the sickest patients. And you either have a response like, I really want to do more of this, and then you go into home crit care, or you think, boy, I'm not sure this is the right thing to do, and you end up going into Jerry's or palliative care. So as you can see, we've had a number of people go to OHSU in POLM or in POLM crit care. We've had a number of people go to UC Davis. In geriatrics, we have a recent person who just graduated from OHSU in Jerry's and someone who just graduated from UCLA. The other place that we've been very effective at getting fellowships is in palliative care. And then there's been a smattering of other fellowships, including nephrology, cardiology, and GI. So what are the benefits? The first benefit is something that's very unusual to receive as a house staff. So most places that you apply, a resident is called a resident and they're not really an employee. At Legacy, you are an employee. So your years at Legacy, if you stay with Legacy afterwards, are years that count towards vesting, towards retirement, and bump ups in pay. Our salary for 2018 for an intern is going to be $59,681. I would expect for 2019 will be about $1,000 more than that. The national average is about $53,000 or $54,000. Insurance is both comprehensive medical and dental, but the most remarkable thing is that the dependents are free. Even though your longest stretch in the hospital is 14 hours, you are given meal cards that should cover all the food while you're in the hospital. This is a benefit of well over $1,000 in addition. All the parking is free, and then there's a mildly reduced membership at LA Fitness. So there's more to Portland than just coming to Legacy, and Portland really is an amazing place. And if you've never spent much time here, it's the kind of place that gradually grows on you. It's got great access throughout the city. There's great restaurants. great coffee, obviously, that everyone's heard of. And then there's obviously things that are close by, like the mountains or the coast, where many of our house staff spend their time off doing other wellness activities. So why should you work at Legacy? I think you'll find that we're really a very cohesive group of residents and faculty. We work together to do team care. Our goal is to do the best care for our patients. We're giving you really unrivaled educational resources, including MixApp, the ACP board curriculum, and a board review course that we cover most of the cost of. We have an evolving curriculum to try to smooth out some of the discontinuities of training, and we call that GRIT. There's top quartile pay. We get great job recruitment for our graduating seniors, and many of these people choose to stay at Legacy. In addition, there's 4 weeks of vacation. So thank you for this YouTube video and watching this. For those of you who are going into a preliminary interview today, you will have about 2 15 to 20 minute interviews. And for those of you who are doing a categorical interview, you'll have about a 10 to 15 minute interview with me, and then another 25-minute interview with one of the other associate program directors. If you have further questions, save them up for the question and answer period that'll occur on your interview day. Thanks again, and welcome to Legacy.